We're live, and welcome to another episode of Machine Medicine's podcast series, Neuromodulation, today and tomorrow. And we're delighted to have Suzette Shahmoon here today to talk about lived experiences in deep brain stimulation. Suzette, thanks so much for coming. You are an independent therapist and also a PhD student at UCL, I understand. Currently, can you tell us a little bit about your background and how you got into this area? That would be really helpful.
Yeah, well, so my husband was diagnosed with Parkinson's when I was 23 years old.
Wow.
And he was 28. So I have a very intimate relationship with Parkinson's disease. And about 12 years after his diagnosis, he had DBS surgery. And it was during that journey of between him on that slope of when he was finally started medication, and then all of a sudden medication wasn't working as effectively, I decided to train as a therapist and started basically to understand what makes people happy. So it was, I went into positive psychology because I found there was so much, I was struggling so much with what was going on in my life. I wanted to make sense of my own experience and his. And then when he had surgery, the team were interested in what I was talking about, and they said, why don't you join us, come do some research and have a look at patient and caregiver experience of DBS. And I'm there. It's been about 5-6 years now.
Right.
And I'm doing my PhD, working with people independently and researching as well. So it's been an interesting journey.
Fascinating. I knew a little bit about your background, but I had no idea that this was rooted in such a sort of personal history. Cool. So, what's the I guess lived experience as a term? I'm probably displaying my ignorance here, but I guess in a sense, it's not. I'm going to try to carefully here, but I don't associate it in my mind with kind of sort of hard science and quantitative approaches. But maybe that's so. What is the kind of what is the approach here? What are we trying to what in this kind of research? What sort of gap are you trying to fill that's not being addressed by sort of maybe more traditional kinds of scientific approaches that as I said to you when we were chatting before, this podcast typically focuses on? That's one of the reasons why we were so keen to talk to you about, there's just some kind of slice that's sort of absent in the quantitative field, but you're able to at least address, if not completely fill. So can you give us some kind of insight into that?
Yeah, absolutely. I think you've got the quantitative and the qualitative, right? These two approaches, and both have their merits. And the point of qualitative research is that there are certain things that stats just don't show. How does a person experience their pain, their trauma of what they're going through? How do you help them through that pain so that they see the light at the end of the tunnel, so they start enjoying their life? Because at the end of the day, everything that we do within the medical field is to give people not just quality of life, because quality of life is, can you tie your shoelaces? Can you make a cup of tea? But also want them to experience happiness, essentially, subjective well-being. And that's where I come from, the world of subjective well-being as opposed to quality of life. I remember sitting down in the early days and it was, can your husband walk? Can he tap his foot? Can he do all of these things? And I was like, yes, he can do all of those things, but he's miserable. And so am I. And how are we going to live with this illness in the best way possible? And you go through an experience which is life-changing or can be life-changing, like DBS. And some people, they will flourish after surgery and others won't. And if you look at the stats, 25% of marriages fail after DBS surgery for a range of different reasons. And so the gap that I'm trying to fill is, firstly, why? Why is it that people can go through this surgery, predominantly most feel better, and yet their subjective well-being isn't improved? And caregivers, the partners, people like me as well, their lives aren't improving either. why. And that's why I went into this research, into this field.
Fascinating. But you're so in a sense, I think you've kind of placed it in contrast to more traditional kind of quantitative approaches, and that makes sense. Are there any kind of ways that that you're trying to sort of get a quantitative handle on the qualitative sort of, especially if you're doing it in the context of a PhD? That must be something that sort of comes up, is it?
Absolutely. So I've just recently finished an interview study where I'm looking at the lived experience of caregivers, so partners of people who've had DBS 1 year and 5 years post-op. And that is about the numbers. You know, what percentage of people flourish after surgery versus percentage of people who don't. And actually, this paper changed 1,000 different times as these interviews evolved. And what came out in the results, it was very much about identity, caregiver identity. And that is a numbers game. It's half of the people, half of my participants, 1 year, whether it was 1 year or 5 years post-op, actually, were unable to let go of that caregiver identity, even though their partners didn't need them to care for them anymore, or as much. They still wanted to be caregivers. They didn't know how to go back into that partner role, that spousal role. And again, that is a numbers game. And so it's interesting. Why does that happen? And again, stats, the stats aren't going to show you that. It's when you sit down, you talk to people, you listen to their stories, that you actually start to understand, how is that happening? What is evolving? What happened to get them to the state where they've adopted this caregiver identity? How do we get them out of it? Is that what's right for them? How do we get them to live a better life? Because, as I said, essentially, that's why we have DBS surgery. We want people to live better lives.
And that's the caregiver, that's the person's spouse or whoever you're talking about there. So one of the things I thought was interesting reading your paper was I think it was all of them that actually used it. So one of the things you mentioned was having the remote control for turning the device on and off, or titrating it up or down in terms of the stimulation strength. And many of the patients actually relinquished control of that to their wives or other caregiver, and they didn't want it. They wanted someone else to. It's kind of surprising, right? Because I think, as you mentioned in the paper, one perhaps intuitively would have thought that, giving somebody that degree of control over their own therapy would be empowering or something, but it seems like they actually voluntarily resigned it. Is that?
And this is just it. It's what led to that. And that's what's happened on the run up in their Parkinson's journey, isn't it? All of a sudden, they've got this illness, which is so disempowering. And they get used to being cared for. They get used to someone being there to do it with them or for them. And then all of a sudden, handing them that power back, for some people, that's a big step. And for some people, it's not going to be so easy to do. And it's actually, let my partner do it for me because I'm used to it. Let my spouse do it for me because they deal with this stuff. It's too much. And so for me, I'm a therapist, right? So I'm always going to come from that background of, okay, so do people need a bit of coaching, a little bit of therapy beforehand to say, okay, are you ready for this? Are you ready to take control back? What do we need to do? What do we need to work through to get you to that place? Or actually, are you and your spouse so comfortable in the roles that you've adopted now that actually this works for you? Because, what works for me might not work for somebody else. For me, I wanted my husband to take care of himself. At the first couple of months, I remember when he had DBS, I did everything. I was always managing the remote control. But after a while, I don't want to be that person. I want him to do it for himself. He's a young man. I want him to be able to go out on his own. And if he can't, because he needs me there to up and down his stimulation settings, why did we have this surgery? I need him to be more of the man he was when I married him.
Got you. And I guess so that it's interesting to hear your story, and it kind of explains why you decided to do this work in deep brain stimulation in particular. I guess it could apply. Does it apply more generally, do you think? Is this a phenomena that you describe in this paper, phenomena that we see with kind of all therapeutic modalities or all neuromodulation, or how general do you think these phenomena are?
So they speak about burden of normality. I know that that's been spoken about with other when treatments. When DBS is used for other clinical issues. But I mean, I've been working with people with cancer, with MS, depending on the treatment and the stage of illness that the person is at. I would say, yeah, I think it's quite common for anyone who has been ill for a certain amount of time, become used to having someone there to support them, because when they've had that support, not everybody is ready to all of a sudden take the training wheels off and it's okay, you can ride by yourself again. I think.
And this is the burden of normality that you mentioned, being
Exactly.
basically having all the sort of standard duties heaped back on your plate, housework, maybe going back to work even, and expectations maybe rising significantly.
Absolutely. And it's not just for the patient. I had one spouse caregiver who I interviewed, and he said, I don't want my wife to get better. I don't want her to have a success with DBS. I want her to remain ill because I gave up my job. I gave up everything to become her caregiver. And if she gets better, then I don't know who I am anymore.
Wow, that's gosh, that's a somewhat paradoxical but understandable kind of phenomenon. One of the other things that I thought was really interesting in your paper was was mention of this fact that there's some kind of, what would be the right word for it? I guess ambivalence around the sort of having a machine inside you, basically becoming a sort of amalgam or a hybrid of man and machine, kind of, and the ambivalence that creates in people. On the one hand, are being helped by this technology. On the other hand, maybe they feel it's slightly dehumanizing or something. Is that something you can talk about?
It is. I mean, I've got personal experience with this. My husband used to say, I feel a bit like a cyborg. This part of my brain now, which is being controlled by a machine. And for him, he used to say it in jest. But I remember speaking to another person who felt dehumanized by it. And he said, I just don't feel as if I'm myself. I'm fully myself. I don't think that's as common as, I think he's more of an outlier. I don't think many people experience that, but it is definitely an experience which a few people who've had DBS have shared with me, where they just feel that I think it comes down to lack of control. I can't control my body, so I need this piece of machinery to control my body for me. And that slightly dehumanizes me. It takes away from my human experience.
Do you think there's anything that can be done about that? Is that just a sort of psychological cul-de-sac that these people are stuck in, or is there a way of kind of talking them out of it?
So again, it's about talking, right? It's about reframing things. It's about, if someone were to break their hip and have a hip replacement, would that having a piece of metal in their hip dehumanize them? We probably wouldn't think of it in those terms, but it does mean that they can walk again. And so it's just reframing it for the individual who's feeling like that, and just helping them to see that they're not the only person who's experiencing a change, a shift in their being thanks to modern medicine. It's just helping them to change their views.
So you think, is it true then that this kind of phenomenon is less common with people that have had hip replacements, for example? I mean, I had hip replacement. I was a congenital dysplasia of my hip, and I had a hip replacement in my early 30s. But I never had this kind of feeling that I was like half machine or something. Is it something about the integration with the brain and the way we think and what our control, as it were, our control mechanism? Do you think this has a special poignancy when it comes to these kind of considerations?
I think definitely. I think you've nailed it. And I think that's why, in therapy we talk about the way we explain things to ourselves. And sometimes when we personalize things, we over personalize things, that's when things can become a little bit more toxic in the way that we view life. And so if you can, and as I said, you depersonalize it. So for you, having hip replacement hasn't dehumanized you in any way. It's helping someone to see things in that way. Let's take it, just because it's your brain, it doesn't matter. Your brain is a part of your body in the way that any other part of your body is a part of your body. And so you just take it away from that essence of my brain is my whole being. It just help them to think of their whole body as a system, as opposed to just one part, focusing on that one.
In a way, though, they're kind of right? I mean, the brain, as the way somebody, I think a nice way of sort of putting it is that, the brain is the only organ that, if something goes wrong, you don't want an organ transplant, right? If you have a heart transplant, you can change your heart. You have a liver, you can change your liver, and you sort of still feel like the same person. If you have a brain transplant, you're somebody else, right?
Yeah,
It
but we're
is
not
sort of, in some sense, essential, no?
Yeah, but we're not changing the whole brain, are we?
Mm.
We're
No,
literally,
quite right.
we're hitting on one small target, whatever it is, the subthalamic nucleus, or whatever it is, the GPI. We're hitting on one small target. We're not changing their brain. We're just stimulating one area of the brain. Hence, I will challenge you and say no.
No, absolutely. Yeah, that's absolutely right. I mean, I guess, yeah, it does get into sort of, the kind of downstream network effects and stuff. But yeah, I mean, it's not a brain transplant. You're just modifying the activity in there.
You're supporting the network in the way that you would support the network if you needed a knee replacement, a hip replacement, a heart transplant. You're supporting the network with just another of our modern medicine.
I mean, how much do you think this is sort of like socially conditioned? I mean, one of the other things that made me think about was that, when people first started doing heart transplants, there was a lot of there was a lot of comment, let's say, that you couldn't possibly do this. The heart is kind of like, an essential kind of, even in poetry and literature and so forth, we talk about the heart of somebody, or as being, in some sense, their essence. And then kind of as it's happened again and again, people have it's become normalized in some sense. Do you think we're still in a kind of sort of an early phase of these kind of technologies, where this is an example of brain computer interfacing, essentially, right? Neuromodulation or deep brain stimulation. Do you see this kind of just as it becomes more and more common, becoming more and more normalized, and people having these thoughts less and less, or how do you see it playing out?
I think it depends on the culture that people come from, that the patients come from. I think there will be some cultures who will struggle for a lot longer than others, potentially.
Can you give any examples? What do you think makes a culture vulnerable to that kind of thing?
So I remember speaking to someone of Asian descent, and her mother had been diagnosed with Parkinson's, and she told me that her mother was from culturally, firstly, they don't like illness in her particular back from her cultural background. So it was seen as a dark spot on their family. So already accepting medication was a big deal. Accepting any help just medicinally. I think if we were to tell her, but she could have DBS surgery, that would be a step too far. It's just too much for that particular culture. I think there is this cultural divide. I think the more westernized thinkers, it's going to be easier for them to accept. I think anyone who has access to, again, if you've got access to the literature, if you've got, good medicine, it's going to be easier for you to ask questions and to learn about the DBS journey over the last 20 years that we've had DBS. People can ask questions, inform themselves, and it'll be easier to assimilate that into medicine. But I think those cultures where they don't have as good access, where there are cultural beliefs around illness, whether illness is something which is brought on by God and therefore you don't mess with it, it's going to be harder. I do think so.
Right. And of course, all of this sort of feeds into how clinicians actually sort of bring up this issue with patients and patients' families and so forth, right? Are current approaches sufficiently sort of subtle and responsive to different circumstances, cultural and social and individual, or do you think as clinicians we're often a little too cack-handed in the way that we go about bringing these things up?
So, firstly, I don't know how many people of the minorities have access in the way that other people have access to treatments like DBS, or whether they want access. So clinicians, look, from the clinicians that I know, and I've spoken to many, most are incredibly sensitive to people's different cultural backgrounds. And so I would say that most people nowadays are aware. There is a certain level of awareness. We speak so much about diversity and equity and inclusion that we know that we have to be more aware of people's cultural backgrounds and beliefs. So if there is training to be had, then go for it. If you don't know enough about other people's backgrounds and how to handle them so that you have situations, I would tell any clinician, go find out. But I think the bigger issue is those people who are not accessing, so that they don't know about DBS, they don't know about the different types of therapies out there for them, these advanced therapies. I think that's a bigger issue.
Right, yeah.
People.
It's kind of it's a difficult one for clinicians, isn't it? Because especially if you live in sort of like, say, London, for example, there's so many different cultures, you know, it's like, in a sense, learning a culture and the subtleties of it is a bit like learning a language. So it's a bit like asking people to speak 20 different languages, right? To be that sort of sensitive and engaged. Is there anything that can be done within the communities, do you think, to sort of improve sort of understanding and access?
Well, it's funny because I'm part of a research team in Cardiff called Learn, where we're actually looking at this issue more with clinical trials for advanced medical therapy. And one of the greatest issues is barrier to treatment because of cultural background, minorities. If you look at a lot of the clinical trials going on for all of these, well, for Parkinson's in particular, that's what our area. Most people who are recruited are white, they're male, they have a certain they come from a certain background. And we're now looking at, okay, how do we broaden that? Because what we don't want to do is make sure that every treatment that comes out is predominantly for this particular type of patient. So we're looking at that right now. How do you access those communities, essentially?
Yeah, it's an interesting question, right? Because I mean, there are one of the other things is there are certainly in for example, cardiovascular medicine, known ethnic differences, predispositions in terms of responsiveness to antihypertensive therapies, and I guess deep brain stimulation and neuromodulation generally is something so poorly understood that we're probably not even at the stage of having any idea of what those differences might be in terms of impact and stuff. So I'm sure you're right in terms of widening the nets of people that we include in the various sort of trials that we have done here. Yeah, it's really, really interesting. So perhaps we can sort of finish up by talking a little bit about your thesis. What are you trying to what are you trying to establish or investigate, and when are you going to finish, and where do you go beyond this? What does victory look like for you?
Oh, okay. When am I going to finish? That is an amazing question. Could not possibly answer. Hopefully this year, if not next year. My whole thesis is looking at well-being, subjective well-being in people with Parkinson's and their caregivers. I am fascinated by how do you live a good life? How do you live a happy life? And life, happiness is essentially, it's made up of three aspects: meaning in life, it's made up of engagement with life, and pleasure. And as you can imagine, living with Parkinson's can affect each of those aspects. So I'm looking at that in caregivers, I'm looking at that with people with Parkinson's, and I'm looking at a very small part of that in people with DBS, with my caregiver study. And the aim is to create a roadmap where you can help people to learn to live with their illness and to be resilient to the changes that Parkinson's brings, but help them to find more meaning in their lives, to help them to find a bit more pleasure in their lives and engage with their lives. But first, I need to understand what underpins that. Is it a personality traits? Is it their natural personality of optimism or extroversion or neuroticism, whatever it is? So I'm looking at all of these different aspects which underpins personality and, you know, clinical variables, and we'll go from there. Let's see what the data shows before I
Yeah. And then for you, after the thesis, are you going to go on to continue this study, or to start trying to integrate into clinical practice, or what is the objective?
To be honest, I do so many different things at the moment. I work with a lot of people with for me, originally it was, as I said, I have this intimate connection to Parkinson's. I understand it very well because I lived with it for 25 years. And so I used Parkinson's as a model of illness. I've worked with people with so many other illnesses. I don't want to just look at people with Parkinson's. I think there is a particular framework which you could probably set out for anyone who's been diagnosed with a long-term chronic illness. I think there are certain elements which underpin everything. And so probably not, I won't pigeonhole myself to Parkinson's.
All right. Well, we wish you all the best, whatever you do end up doing with this really interesting research, and just a real eye-opener to chat to you today about this sort of angle on things, which I think is probably too infrequently sort of addressed and utilized. As I say, you know, we're on this podcast guilty of it as much, if not more than others, focusing on the technical and the scientific and the medical, when, as you say, you know, ultimately the subjective experience is the prism through which all disease and health is experienced. So you know, it's sort of perhaps of paramount importance. So thank you very much, Suzette. We'll watch your sort of future meteoric rise with interest, and hope to catch up again sometime soon.
Thank you so much for having me on.
Cheers.